All right. Tonight I am joined by Roberta Nole. She is owner of Nolaro24. We've seen her here before. We've talked about a few different foot types so far, so we're continuing that series. Nolaro24 has the QuadraStep system, if you're familiar with those orthotics, and they also have the LittleSTEPS system, and then they've just launched a new prefab called TriSTEPS. So they've got three good options for you. And of course, her email address and stuff is displayed here, so you can shoot her an email or a phone call or a text, and she'll be happy to help you. And I am going to turn it over to you, Roberta.
Thanks, Anne. Thanks for the nice introduction again. And yeah, tonight we're going to I'm going to give a little bit of background about the QuadraStep system methodology and how we look at foot types, because I'm not sure who in the audience has heard it before or hasn't heard it before. So I always like to start with a little bit of an intro. And I always like to start with a little bit of reference to pediatrics, because you can't treat the adult foot if you don't know how it was formed. So we're going to start with a little pediatric overview for a few slides. And I'm going to be focusing in on what we kind of take for granted, the pes planus foot type, the Fred Flintstone foot, we like to call it in our field. So, Anne already gave me a nice introduction, so we can skirt over this. But basically, I'm going to talk a little bit about my patent and how it identifies the 6 different foot groups that you see in the background of my Zoom screen here. So we'll get to that in just a minute. But when we talk about flat feet, I think it's important to differentiate between what I call the true pes planus Fred Flintstone foot. And that's a foot that when it's fully pronated, the heel is vertical to the ground and the foot arch is dropped. The foot is splaying out, usually medially and laterally, kind of like a plunger, straight down compression. We want to differentiate that from the F quad foot, which we call the failed foot. And the failed foot is when pronating to a vertical heel alignment alone isn't bad enough. So we're going to really crank that calcaneus out into heel valgus, and we start to compromise ankle alignment and get a lot more what we see as positive toe sign, too many toes laterally. You'll notice in your typical Fred Flintstone foot, you don't have a positive toe sign. You'll see splaying laterally, and you'll know why more as we go through the lecture. But really, when the foot is done pronating, the toe sign in the Fred Flintstone foot is usually normal or neutral. You see toes on both sides of the foot. So this is the 24 foot type chart that I use in our algorithm for identifying 24 different congenital foot types. That's part of the patent. But for simplicity in training and application to our prefab system, so for those of you that don't know, is I do own a custom orthotic laboratory, and I fabricate a lot of custom foot orthotics. But I also use our QuadraStep prefab system, and in many, many cases, that's just as good as a custom foot orthotic. No, you can't bill it under the L3000 code because it wasn't made to a model of a patient's foot, but it has every bit of the same correction. So why would we do that? Why not just make customs? Well, not everybody in your practice is going to be able to afford a custom orthotic. So the QuadraStep gives you a great alternative for about half the price. So we can get into MSRPs later if people want to know that in the Q&A section. But for now, let's stick with the matter at hand. There are 6 different color-coded foot groups for tonight's lecture. We're going to be focusing on the D quad. I am going to speak briefly about the B quad and briefly about the F quad, but today we're really focusing in on the Fred Flintstone foot. So the feet on the right side of the chart are the flatter of the foot types. The A quads you'll see has a high arch. That's our pes cavus foot type. And the C quad has what we might consider to be the normal looking arch, but it's not always quite as normal as you think. And then the E quad is kind of moderately pronated. There is some dropping of the arch, but there still is an arch. You could, in the E quad, you can usually put your finger under the arch and wiggle it up and down a little bit. So it's a pronated arch, but it's not flat. These feet on the right side are I call them flat, flatter, and flattest. like the three little bears, but in foot world. So starting with the D quad, the D quad are usually come from children that are born with flat feet, so congenital pes planus. We want to differentiate physiological flat foot from persisting pes planus persisting into adult life. So we're going to expand on that. The B quad are usually kids, but also smaller adults can maintain what I call their B-hood into adulthood. But a B quad is somebody that walks in tow. And we do see in tow gait more in children than in adults, and that's from a mass reason, which we may or may not have time to get into tonight, but that'll make you call me and find out more information about that. But kids who have flat feet will tend to walk in tow, they'll walk on their tippy toes. They may have torsional deformities like metaductus of the forefoot, or tibial torsion or femoral anteversion. So there are a bunch of reasons why kids walk in towing that are pathological, like those medical conditions like metatarsus adductus or torsion. But there's a lot of kids who walk in towing and it's idiopathic. They don't have an anatomical reason for in towing. And those kids are, a lot of them have adapted their gait to walk in towing because they have flat feet. Okay, and I'll explain why. Then kids who mature into their adult bodies and you acquire your adult foot type by the time you're about 12 to 13 years old. And as the body mass gets bigger when they're in their teen years or into adult years, they're going to acquire what we call adult acquired flat foot or posterior tibial dysfunction, posterior tibial tendon dysfunction. So I like to think about there being a D and an F quad, which is basically a worse D. And a B is sort of a better D, but that's debatable. We'll talk about that in a little bit. So there's a lot to add to the confusion with kids. There's a lot of different terms. There's physiological flat foot and developmental flat foot, which are kind of synonymous, and those represent the normal flat-footedness that kids have at birth. So we know kids have flat, fleshy, pudgy, cute little flat feet, when they're born, but they should develop an arch by the time they're at least 4 to 5 years old or 5 to 7 years old. It varies among the literature. But eventually, by at least 7, they should have a normal arch. Pediatric flat foot is another broader term that's been used. Pes planus, congenital flat foot, flexible or false flat foot. I love all these terms that really confuse us. The one I like to lean towards is persistent flexible flat foot. So if you're a child that was born with flat feet and you didn't outgrow it by the time you're 5 to 7, then you have a persisting flat foot. But if it's a typical one, it will be flexible. If you see rigid flat foot as a child, then we have to be thinking about anatomical regions like coalitions and things like that. So early intervention is what I'm arguing for and positioning myself to be an advocate for early intervention for children with flat feet and not ignoring the problem. So really quickly, Balmassi's rule of 7 says how much flat-footedness is normal? Well, it's relative to a child's age. So if you apply Balmassi's rule of 7, in this first picture, let's assume this is a group where kids might be 1 to 5 years old. So let's say the picture we're looking at is a 1-year-old. If you apply Balmassi's rule of 7, you take the number 7, subtract the child's age, so 7 minus 1 is 6. 6 degrees of heel valgus is considered normal for a 1-year-old. But let's say that child in this picture was 5 years old. Applying Balmassi's rule of 7, 7 minus 5 is 2. That child should only be everted 1 or 2 degrees, or 1 to 2 degrees of valgus by the age of 5. So this would be too much flat-footedness for a 5-year-old. Then we hop over to the second group here, and 7 minus 7 is 0. So by the age of 7, the heel should be vertical to the ground. Then at that point, we should start to see an arch formation. You should start to see the presence of an arch. By the time we are 10 to 13, the heels start to invert. Let's say we're looking at a 10-year-old. 7 minus 10 is -3. The heels should be inverted 3 degrees or so by that age group. Ideally, we want to see a heel invert at 4 or 5 degrees by the time they mature into their adult foot shape. And for reasons we're not going to be covering tonight, that moderately inverted heel alignment does lock the midfoot. And that means that the body should be able to maintain that normal arch height under the load of a normal average size adult, maybe somebody 150 to 200 pounds. Now, if you have this perfect foot alignment, but you weigh 400 pounds, the arch is going to give under the excessive mass. But let's go back to this group here, the 6 to 9-year-old. The 6 to 9-year-old who attains this vertical heel alignment is a pediatric D quad. Now, if your heel is vertical at the age of 7, yes, you'll have an arch because you may weigh 35 pounds or 45 pounds. But if you don't mature past that into the next, when you become a tween, when you start that, if that heel doesn't start to move into an inverted position and it maintains its vertical alignment, then as you mature into a body that weighs 100 pounds, 125 pounds, 150 pounds, that's going to be your Fred Flintstone foot. So this is why I wanted to cover pediatrics, just to understand the origin of where that foot evolves from. Now, obviously, you never want to build a structure on a weak foundation. You wouldn't build a house on sand, and you would, if you did, you wouldn't be surprised if it collapsed. Same thing for your feet. If you don't have a stable foundation from your feet, you can't have good posture. So we see a lot of postural adaptations, and a lot of people are unaware. But I do quite a bit of orthotics in my practice, maybe about 60 pairs a month or so, and half of them might be customs, half of them might be prefabs. Doesn't matter to me. It just matters on what the goal is, and the goal is always managed the same. Whether you use prefabs or customs, our goal is to enhance and stabilize posture. So what I always explain to my patients is that only about 30% of the patients I dispense orthotics to come to me because they have foot pain. All right, it's not all plantar fasciitis. It could be shin pain, knee pain, hip pain, back pain, because it's all related to the way that you stand and walk and how much stability you have or don't have in your foot and ankle structure. This is something I'm just going to give you a quick kind of commercial on, because this is something I've been working on quite feverishly, and I want to release it. I think Ann is going to allow me to do a presentation on what I'm calling the Nole Bob 10 foot index. Half named after my father, Bob, who I admired and missed greatly. But this is a clinical algorithm or a series of benchmarks that you can use to help determine whether you should treat or not treat a child that you're seeing in your office. So biomechanical orthotic benchmarks, hence Bob. And there's 2 tables. The first table is clinical history and functional indicators. These are things that you're going to be discussing with the parents. Common things like are there gait abnormalities, delayed milestones, hypotonia, hypermobility, genetic things. This is kind of a table. I actually have revised it since I put this slide together, but you get the idea. We're asking parents questions about their foot, and if they score 4 or more on this table, that would indicate go ahead and treat. On the second table, we're looking more at structural and functional things about the foot. Is there excessive heel valgus relative to Massey's rule of 7? Is there a arch that is planus, but it reforms when they're non-weight bearing? Is there medial talar bulge? What happens in single limb or double limb stance? How about a Jack's test? Are there transverse plane and abnormalities like torsion in the femur or the tibia? Frontal plane malalignments like tibial varum or knee valgus, thigh foot angle, tibial torsion for moral anteversion measurements. Are they egregious? And is there a leg length discrepancy? So I'm kind of fine tuning this still at the moment, but this is kind of the gist of it. So the plan would be is if you score 4 or more on either table, then that would indicate to treat. But if you score 6 between the 2 tables together, that also could indicate to treat. Again, there are other parameters that I'm building into that, but that's something that I'm working on because I get a lot of questions. I get a lot of people that call me and say, hey, Roberta, I have a 10-year-old and he's got really flat feet, doesn't have foot pain, but he's got a lot of growing pains and he's having a hard time keeping up with the other kids. Do you think I should treat? To me, that's a no-brainer. Yes, intervene when you see egregious pes planus never leads to good things in the adult body. So another thing I like to talk about is childhood obesity. And there's a lot of articles out there that infer that chubby children get flat feet. And I will sit here and argue the opposite all day long. I think if a kid is born with flat feet like this, chances are they're going to get better at video games or TV watching than they are at soccer. So there's a vicious cycle of flat feet, decreased strength, balance, and coordination, avoidance of physical activity, gaining some weight, alters the gait more. That increases pronation and effects on hip, knee, and ankle alignment, lower back alignment, and the feet get flatter and this whole cycle continues. So give that some thought when you're treating your kids. So for managing kids with pes planus, the precursor to Fred Flintstone feet, we can do custom foot orthotics, but I will tell you, I own a custom orthotic lab, and I am not an advocate of custom orthotics for kids. I think it's completely unnecessary. If there are really significant issues like rigid flat foot and things like that, yeah, sometimes we have to go custom. But even with those feet, I feel comfortable modifying a prefab. We use, obviously, I'm recommending the LittleSTEPS. That's my product. It's got the same exact features as a UCB custom foot orthotic. 30 millimeter heel cup depth, high medial and lateral phalanges on both sides of the orthotic to cup, secure the foot and the device. Medial rear foot posting, I usually advocate 3 degrees to start with, and then a medial skive to keep the heel from pronating inside the heel cup. So when do we use LittleSTEPS, or what are they good for? Supporting flat feet, managing heel pain or Sever's disease, reducing growing pains, discourage toe walking, which I'll cover more in a slide or two, and improve strength or address low muscle tone. So here's the kid with flexible, persisting flat foot, whatever you want to call it. And here he is 10 seconds later standing on a pair of prefab, LittleSTEPS, night and day. Next patient, move on. It's really, really easy. Those kids that have that supple flat foot, they're small enough. They don't need a very rigid orthotic. The LittleSTEPS is made out of a thermoplastic rubber material. It's very conforming. You can heat mold it if you needed to, if there was a little navicular prominence or something like that. It's durable. It's washable because it's made out of rubber, so it's easy for the parents to keep it clean. So many reasons I prefer that over custom. Toe walking is another topic I like to address in kids. Congenital toe walkers might be walking on their toes because of heel cord shortening and might need surgery, lengthenings, Botox injections. But many of the kids, and probably the majority of the kids that we see with persisting toe walking, is idiopathic toe walking, meaning there's no restriction in ankle dorsiflexion, but for whatever reason, they choose to walk on their toes. Well, there's a really simple explanation for that. If you're looking at this kid with really flat feet, that kid has a very unstable foundation. So imagine we've all stood on our couch pillows to hang a picture over the couch or fix your curtains, and you know how unstable that feels and how wobbly you are. Well, if you're a kid that is walking around with really hypermobile flat feet, and on top of that, you don't really probably have very great muscle control at that point, your gait is really floppy and uncomfortable. So how do they fix that? They go up onto their toes. Now, how does that help? When you go up onto your toes, we contract our gastroc soleus. The gastroc soleus isn't just an ankle plantar flexor, it's also an inverter supinator of the subtalar joint because it attaches medial to the subtalar joint. So when you go up on your toes, you invert the heel. And remember, I like an inverted heel. 4 or 5 degrees is just fine and dandy. So when you go up onto your toes, you invert your heel. Your forefoot is on the ground. Now you're extending your MTP joint, so you're kicking in the windlass mechanism. And now we have a locked metatarsal joint, which creates stability. So kids walk on their toes because they find they have more control of their bodies by going up onto their toes. If there is truly heel cord restriction, I recommend the Equinus brace by fixequinus.com, Patrick DeHere's brace. If anyone hasn't heard of that, if a podiatrist in the audience, this is fantastic brace. It goes above the knee and it deals with both hamstring and ankle contractures, which is critical to getting a good release of the muscle. So there is a nice plug from my colleague. And this is why I think kids walk on their toes. It's not idiopathic, it's flat feet. Another thing we are addressing is in-toe walking. And in-toe walking, I don't have time to get into a lot of it today. We know there are torsional deformities, proximal tibial torsion, use a Wheaton KAFO, metaadductus, use a Wheaton AFO or BVAX therapy, and femoral anteversion. Cross your fingers because there's nothing, no good device for treating femoral torsion. But we can treat these things that we theoretically don't have a lot of control over by education, by physical therapy to strengthen the core and the hip abductors, and by discouraging postural imbalances like W sitting. In the foot world, in the orthotic world, again, a prefab that we provide is called the LittleSTEPS gait plate, and it extends longer on the lateral side. And that is a great way to create a lateral rotation. And that lateral rotation is really coming from the hip. So I'm a PT by background, so I like to think of a gait plate as a hip re-education device. So my goal for a gait plate is to discontinue it. I need to use a gait plate in many cases when we see kids that are in-toeing mildly and they have flat feet. I might just try a basic LittleSTEPS orthotic first. But if they're really in-toeing to the point where their coordination is really off or they're tripping over their own feet, then you might need to interject with this gait plate for a period of time to encourage facilitation of the lateral hip rotators. Again, there's a lot more I can get into on this, but this is not the topic of tonight's discussion. So more to come on that. If anyone's interested or has questions about gait plates, we can maybe address them at the end, or you can reach out to me on my email. Now the B quad is the foot type above the D quad. And I remember I called the B quad the better D, or the smarter D is what I like to call it. And that's because kids who have a D quad foot, they learn to self-correct by either in-toeing or idiopathic toe walking. And again, why are they doing that? To get that first met to plantar flex and stabilize on the ground so they can try and resupinate. Most of the time in the B quad, that's going to fail because kids don't have good strength, or a lot of them might have low muscle tone. So they can't really control that motion with their musculature. So they walk in-toed, and that can create secondary problems. So we really want to try, if you're seeing a kid that's in-toeing this much, try a gait plate, monitor them every 3 to 6 months and see if it starts to resolve. Once the gait gets a little bit straighter, then revert to using a standard LittleSTEPS or whatever orthotic you want to use. Now the D quad that gets worse will turn into an F quad, and we'll talk more about that. So now let's get past pediatrics. Pediatrics, I mean, meaning maybe from 1 to 13 years old. Once a child's 13, a pediatric case is turning into a teenager, they actually have their adult foot shape. So this is suggesting, and I want to bring to light that you have a window to try and influence proper development of the foot. No, there is no evidence-based science to say that you can, but I argue there's no evidence-based science to say that you can't either. And I don't understand, quite honestly, the fear of treating children's feet, because it makes no sense. When we see scoliosis, we brace with the scoliosis brace. When we see crooked teeth, we put braces on their teeth. When we see a child with a misshapen head, a baby, an infant, we're not afraid to put a helmet on it and reshape their cranium and contort their brain position, but we're afraid to put a pair of orthotics in a kid's shoes that's supporting the whole entire body. To me, that makes no sense. So we want to do that between the ages of 1 and 10 or so, 1 to 12, because by the time they're 13, it's too late. They have their foot type. Now, frankly, quite a lot of it will be genetic anyways. You inherit your parents' feet, and there might not be anything you can do to completely change that, but you can prevent it from having worse consequences. So really quickly, we're going to review 4 steps to foot typing. I always say don't put all your eggs in the arch basket, but we're going to start by looking at arches. And you can just ask yourself one simple question. Does the patient in front of me have a normal to high arch? And if the answer is yes, then you know you are already looking at either a yellow or a blue, an A or a C quad foot type. So an A is your pes cavus, and a C is your quote unquote normal arch looking foot. If the answer is no, which will be no for the Fred Flintstone, that would include all 4 of the remaining categories. So B's, D's, F's, and even E's, because E's are moderately pronated. They're less than a normal or perfect looking arch. So in the next step, we're going to turn them around and we're going to look at their toe sign. Now this is done in a relaxed standing position, and I get behind the patient and I'm looking to see, do I see a neutral toe sign? A neutral toe sign means I can see the big toe on the inside of the leg, and I can see the lesser toes on the outside of the leg. Same thing for the C and the D. That means that you have a neutral forefoot, so that when your forefoot comes down to the ground, it loads evenly, and the foot might splay a little bit, but when it does that, we see toes equally on each side of the leg. A peekaboo toe is from a forefoot valgus, and a peekaboo toe draws your toes inward. It's the opposite of what we see with forefoot varices, which I think most people are more familiar with. If you see a forefoot varus, then in order to get the medial side of the forefoot down to ground, we have to pronate into propulsion, and that abducts our forefoot and leads to too many toes laterally. And if you look medially, you see you can no longer observe the great toe. It's missing. All the toes have drifted to the outside. So forefoot varices abduct your forefoot, and forefoot valguses adduct your forefoot. So quick quiz here. I wish I could hear you guys, because I'm gonna pretend like I'm on the other line and on this one, like a badminton game. If you see a patient standing in front of you and they have a pronating arch, the first question you'd ask yourself is, does this patient have a normal to high arch? And you'd say, no, they're a pronating arch. So we're going to eliminate A and C. The next thing we do is we turn that patient around and we check their toe sign. And if we see that patient has a neutral toe sign, then that means they're in the middle row. And guess what? That's your Fred Flintstone foot. A Fred Flintstone foot is a pronated arch with a neutral toe sign. I'm going to go through these quickly because these are the other feet that we're not talking about tonight. The C quad is a normal arch with a neutral toe sign. A B quad is a pronated arch with a peekaboo toe. You see too much of the big toe because remember they're in-toe walkers. And an A quad is a high arch with a peekaboo toe. All right, so if you see a peekaboo toe, there's no confusing a A or a B. A B is really flat and an A is really high. And then people who have a pronating foot and a too many toes laterally could be either an E or an F, but the difference is going to be noted in the severity. An E quad will pronate, and there'll be some strain on the medial ankle, but they'll maintain something of an arch. Whereas an F quad goes into that pes plano valgus, where the heel rolls out into eversion or valgus, and that draws collapse at the ankle joint, or ankle pronation combined with subtalar joint pronation, and that leads to posterior tibial dysfunction. So those are the 6 combinations of step 1 and step 2. Step 1, arch height. Step 2, looking at toe sign. In step 3, we watch people walk and see how they walk. You'll see there's 6 different gait patterns. If any of you have not heard this lecture before from me, reach out to me. I do have recorded videos to share. And then because of the way you walk, we'll see specific callus patterns forming. And we have all these slides you see with the 24-foot type, the 6 quad side, the callus sides. We do have all these as print material. The way you walk leads to a set of symptoms. So let's focus for an example, the case we're talking about tonight, the D quad. Of course, they can get plantar fasciitis. They have flat feet. Metatarsalgia, and we're going to see why. You can see that the first met's going to get pushed out of the way. Weight transfers to the second metatarsal. You can get avascular necrosis in there, Friedberg's, Friedberg's, whatever it's called. I can't remember at the moment. But you can get stress fractures in there too in runners. Patellofemoral pain is common in kids and adolescents and young runners. And posterior tibial tendonitis because that ankle is a bit strained in the D quad. I have also written an article. We'll leave this up here for a minute if anybody, or it's on my website too. There's the website link down here. But this is an article I wrote called Management of the Adolescent Athlete by Foot Type. So I list various teen-related, youth and teen-related musculoskeletal stress disorders that can happen because of an A quad, B quad, C quad, D quad, and so on and so forth. So it's injuries by foot type in kids. All right, so 24 feet, 6 quads. Let's get on to the D quad. Now remember, the D quad does have 4 feet within the D quad, so not every D quad is going to look exactly the same, but this is pretty close. This is pretty much what you're going to see. In standing, collapse of the arch, vertical heel, neutral toe sign. Pretty easy to pick out. I love to look at internet photos and just go, oh, that guy's a D quad. Oh, this girl has a pretty decent arch. She's a C quad. You know, fun to do that for practice. All right, so our Fred Flintstone foot is on the right side of the chart as a pronator and in the middle row. So this is your pes planus foot. And I want to play this video for you. This video shows you that basically, if you can pronate your subtalar joint, you will pronate your subtalar joint, and you will pronate it until something stops it, and that usually is the ground. So if a patient is able to pronate, they will start to pronate the subtalar joint. Their calcaneus moves to vertical or eversion, depending on how bad it is. And when that happens, the ground is pushing up on the lateral column of the foot. So when that happens, let me stop this when they're fully pronated. When you're fully pronated, the ground has subluxed your calcaneocuboid joint, and the whole fifth ray is getting pushed up. Fifth ray, cuboid, lateral calcaneus. And so the peroneus longus, which is supposed to operate around a pulley system created by a stable calcaneocuboid joint, or the lateral arch of the foot, is disrupted. So the peroneus longus is slackened. Sometimes you'll get tendonitis over there. But mostly what ends up happening is because it's slackened, it loses its mechanical advantage to stabilize the base of the first metatarsal. And therefore, the first ray is unstable. So everybody looks at flat feet and says, oh, problem is an unstable medial column, an unstable first ray. But really, the problem starts on the lateral column. And this is often neglected to be addressed. You need a wide orthotic for this foot type, because if you don't have it wide enough, the lateral column of the foot will roll over your orthotic, and you will not capture or stabilize, restore that integrity of that lateral column, and therefore you won't accomplish the mission, because the first thing you need to do is restore peroneal functioning. Another thing is we see this overstretched plantar fascia. First ray gets jammed dorsally, so you can kind of see it even in this grainy video, the beginning of a dorsal bunion or exostosis and the development of hallux rigidus or hallux limitus to hallux rigidus. Posterior tib tendon is overstrained, the deltoid ligaments overstrained. The tibia follows into internal rotation. The femur follows the tibia, and the kneecap drifts laterally. So we get patellofemoral pain syndrome, tibial tendonitis, plantar fasciitis, metatarsalgia, bunions, hallux rigidus, and possibly some peroneus or peroneus brevis issues. So let's watch this person in motion now. Let's watch this gait video. So here's your D quad walking, and let's break it down. Let's go ahead and stop this gait, this step at heel strike. So here's heel strike. And at the moment, this heel is inverted a couple degrees, but really quickly, by the time we hit foot flat, by the time the forefoot hits the ground, that pronation is usually completed. This is your D quad. The D quad pronates to a heel vertical position, and then the medial side of the foot is on the ground, and mission for the subtalar joint is accomplished. It loaded the medial column of the foot. But because the heel is vertical, and this woman was a 19-year-old student at Quinnipiac University, and I think she had shin splints. But basically, her overpronation at this point isn't complete because she doesn't have ligamentous stability, because she's always, since she was a child, she's always walked around on flat foot. So what we're going to see is as we advance into single limb stance, into mid stance, the arch has collapsed even more. Okay, so the arch is collapsing more, but the heel is still vertical. Okay, you might look at this fat pad here and think it's in heel valgus, but here's the lateral border of the calcaneus right here. So the infracalcaneal fat pad will often migrate and get compressed and squished over laterally, and that will give the illusion of more heel valgus. But the heel's vertical, the arch is collapsing, the lateral column is getting pushed dorsally because it's unstable and the ground is firm. So it pushes the lateral column up. And now the first ray is unstable and the first ray gets pushed dorsally. So when we go into propulsion, you're going to see, actually, let's look at this on the right foot because I think it's a little clearer on the right foot in this video. I'm going to try and stop that right about there. So as we're coming up off the ground, you can see almost without an x-ray, you can see kind of the development of a increased IM angle between the second and third metatarsals. You'll notice with a lot of these Fred Flintstone feet that you'll get increased web space between the second and the third, usually sometimes the first and the second. But what happens is because this weight has transferred from the first metatarsal to the second metatarsal, as the foot is splaying laterally, because it's the Fred Flintstone foot and it's got all that foot splay and instability, it's dragging the lateral column of the foot away from the weight-bearing point, which is the second metatarsal, and that increases the web space between the second and the third. So what else are we going to see? Neuromas, interdigital neuromas, reversal of transverse metatarsal arch, and as we already said, hallux limitus or hallux rigidus, because you are, oops, I didn't mean to do that. As you're going into terminal propulsion, you're loading, stop that again, you're loading this first metatarsal and jamming it dorsally, and you're going to end up really driving and compressing against that the dorsal aspect of the first MTP joint and getting some hypertrophy and osteoarthritic changes, even at an early age. So there's a callus that we typically see with the D quad. It's the second metatarsal, and as the foot gets worse, let me go back. As the D quad gets worse, it will start to transfer weight over to the third metatarsal as well. And that's when the D quad is turning into the F quad. And I always joke when I'm teaching my class and I say my mama's favorite tune for this kid is "Mama, don't let your babies grow up to be F quads," because that's the foot nobody wants to become. So here it is. Here's the features: vertical heel, dropped arch, splaying of the foot, increased internal rotation, increased femoral rotation, lateral drifting of the patella. Here's the three key things you see in gait. And here are the symptoms we just covered all of these. So what do we need this orthotic to do? So that's how you want to make a good orthotic. Whether you're doing custom or prefabs, you want to ask yourself, what is it that I want this orthotic to do for me? Well, this is a very unstable hyperpronated foot, and it's caused this patient to say have plantar fasciitis. So why does he have plantar fasciitis? Well, too much pronation. So why is he overpronating? Because the subtalar joint can. So what we're going to do is to give this guy an orthotic with a moderately deep heel cup. I like to have at least 20 to 25 millimeter heel cup depths. I'd like it to be at least 25 to 30 if I'm calling it a UCBL when I'm doing customs. This QuadraStep prefab has about a 20 millimeter heel cup depth. So it's a pretty good one. So we're going to give this person extrinsic posting. So what's the difference between extrinsic posting and intrinsic posting? Intrinsic posting is when you're bringing the ground up to meet the foot. So let's say you had an inverted heel. You just fill in the void under the medial calcaneal condyle. But in this case, we have a vertical heel. And I don't like that. I want that heel to be inverted 4 or 5 degrees if I can, or at least 3. So I'm going to take this orthotic and we're going to put I start with the 3-degree post. You can add more with stick-on widgets if you want, and we provide those with the product. So starting with 3 degrees of medial posting, I'm going to take this vertical heel and intentionally invert it 3 degrees. I also have a little bit of a medial skive on the inside of the heel cup, and that's a little pressure underneath the sustentaculum tali to keep the calcaneus from everting inside the heel cup. So now we've inverted the heel. That's a good first step. But what's more important is what we're doing with this orthotic shell. I'm going to use this one because you can see the features better in this view. We need a wide lateral flare, and we have a little bit of a built-in bump, a little bit of a raise underneath the calcaneal cuboid joint, and we have a gully under the 5th ray. So if you can see my hand, the D quad has kind of a collapsed lateral column. So that little calcaneal cuboid bump lifts the calcaneal cuboid joint, and the gully drops the 5th ray, and that restores the lateral arch of the foot. So those features, those lateral column stabilizers, this flare, you need a lateral flare, a wide lateral shell. Otherwise, this hypermobile Fred Flintstone foot is just going to splay right over the edge of your orthotic, and it won't work. So it's going to need to be a wide device. And people will say, well, that's not going to fit into a shoe. I will argue the contrary. It will, because these people that have this foot type, they come in wearing D width, double E, 4E width shoes because they know they have wide feet. So don't worry about that. So we also have this in 2 widths. We have a narrower version and a wider version for the people who have super wide feet. So there are a couple widths you can choose from. So those are the features that I think are really important to include on the lateral column of the foot. And then we have a good, decent arch support here. And that's all you need. You don't need any forefoot correction because this person, the D quad, has a neutral forefoot. So there's nothing to manage there. This whole entire hyperpronation is coming solely because the rear foot is able to pronate at the subtalar joint to a vertical position. And that's not good unless you're a kid that weighs 35 pounds. So we really need to counteract that excessive pronation and the hypermobility that usually goes along with it. So this is just a summary. I'm going to skip over this slide to catch up on time a little bit, but you can see too much subtalar joint pronation. Here's the patient, the left foot in subtalar neutral. Here they are standing, just that Fred Flenser. This is the compensation. You ready? Boom. That's it. Just straight up and down like a plunger. This I'm not going to cover tonight, but I will give a little teaser to our masterclass program in our advanced video recordings where we actually cover all 24 foot types and specifically delve into each of the 4 foot types within each quad, but we don't have time for that tonight. But here's some videos that you can wish you could have learned more about. All right, so skipping through that. Now I want to get into the aging D quad. What happens as a D quad gets older if they don't wear appropriate shoes and if they don't manage their hyperpronation, they will turn into F quads. Not all of them. Some of them will maintain their D quads, but they will have a lot of forefoot splay. They'll have fungal nail beds because their toes will grab at the ground a lot. Hallux rigidus will happen. You'll see hyperextension because final propulsion will end up being at the sulcus of the hallux. So when you see a lot of this forefoot splay and toe deformities, you may want to consider adding a met pad to the orthotic, or if you use our QuadraStepS, don't forget you can ask us to add met pads and add a folding top cover. That can be done. So D's gone bad are our F quads, and that's when we start to see the eversion of the calcaneus going into heel valgus. The failed foot, we definitely don't want to be here. And D quads, remember, are born with a neutral forefoot. So what happens? Do they grow a forefoot varus? This is an acquired forefoot varus. When we see a forefoot varus in the F quad, it happens because when they were a younger D quad, remember the ground keeps pushing and pushing, pushing that first ray up. And then eventually the first ray pulls the second, then the second pulls the third, and the third pulls the fourth. And we develop an acquired forefoot varus, which is truly more of a forefoot supinatus. It's not a congenital structural forefoot varus like we see with the E quad. The E quad, they have forefoot varuses, but those forefoot varuses are rigid and they've been present since birth, or since the foot evolved during childhood, I should say. So really quickly, I'm just going to show us a little capture of the D quad versus the F quad. And you'll see, if this one will play for me, a really significant difference. So let's stop the D quad at mid stance and the F quad. And if you compare these two videos, let's see if I can get that shadow out of the way. You're going to see the D quad. Oh, let's stop right there. The D quad has a neutral forefoot, a vertical heel, a splaying forefoot, dropped arch, first ray is elevated, lateral column's unstable, but the F quad has all of that, but it then now adds in that ankle pronation, more heel valgus, and a positive toe sign. It's much more dysfunctional. Remember, D quads, they get patellofemoral pain disorder. F quads have ACL tears, medial compartment syndrome of the knee, torn meniscus, total knee joint replacements, total knees, total hips. They could all be avoided, or a good portion of them can be avoided by managing bad feet from childhood on up. Hence the Nole Bob 10 plan. All right, so here's your F quad video. I just showed you that one F quad. Here's an older F quad. I like to show this video to show the effects of aging. And what you'll see is, look at that, as that heel cord becomes tighter and tighter because flat feet develop heel cord tightening, we start to see the development of a fourth rocker with breakdown of the midfoot. Your diabetic patients that are Ds and Fs are going to be really prone to Charcot foot because of those mechanics. And there's the younger F quad. Older F quad. Okay, and the F quads, remember the callus on a D quad is on the second, but when it becomes worse, it transfers over the third metatarsal, and then it transfers weight to the fourth metatarsal, and you get what I call the cyclops callus. It's kind of a more diffuse callus under the whole central mets, and a lot more transverse arch, metatarsal arch reversal. So anyways, takeaways in case I'm still being recorded. Pes planus takeaways, early intervention is the key. Flat feet and in-toeing are common, but not always benign. So we want to treat, again, manage things. Prevention, prevention, prevention. Address kids early. And don't forget, when you're making custom orthotics, to go ahead and stabilize the lateral column. That's often overlooked and will lead to orthotic failures. I'm going to open up the chat and the Q&A. Just give me a second because I'm new to this. So I have a question here from Stravos. What is the best way to approach pediatricians to educate them as to why their patients with flat feet ought to be referring patients to a podiatrist? So I think that's a very good question. And I just recently was offered, I called the pediatrician's office and asked if I could get in there and talk about kids' feet. And they said they would give me 20 minutes. Well, I'm going to tell you that 20 minutes turned into over an hour and a half. They were totally engaged. They don't think they're going to be interested, but once you get in front of them, and I have some really good handouts and things that I can share with you, Stravos, if you're going in to do a lecture for a pediatrician. But you want to talk to them about, joke with them and tease them. Just say, I know you're taught it's normal for kids to have flat feet, but it's not. And I have another article that I wrote called Pediatric Mythbusters, which lists, 4 or 5 common misconceptions about kids' feet and why waiting to see if it goes away is not a sound medical treatment plan. That's neglect. So anything that you guys have my email, I should type it in here. Hold on, let me type in, I'll type in my cell first. So there's my cell phone number. And my email is Roberta N at Nolaro, making sure I don't type wrong, 24.com. So there it is in the webinar chat. Anybody who wants any of the information or you have questions on any of the content, feel free to reach out to me directly. Hi, Dr. Whitaker. I see you're with us, and you're asking about Seaver's disease, and said little steps are good for this. My question is usually Seaver's occurs in 8 to 12-year-olds. Could you please clarify? Thank you. Yes, I agree. You will see more Seaver's in 8 to 12-year-olds, and at that time they're probably turning into an equad. Equads are actually more prone to Seaver's disease than D-quads, but it doesn't discount it from the D-quad. So that's a good, I'm glad to see that you learned that, Sarah. That was awesome. So, but equads, if you see a tween, let's say you see an 8 or a 9-year-old. I have seen 9-year-olds that are wearing adult size shoes because some kids just grow really fast. So a lot of times I'll need to take a LittleSTEPS and turn it into an equad by adding forefoot posting. So we can do that for you. If you have a kid that's is a LittleSTEPS and it looks like their foot is sliding off the front half of the orthotic, or it's not supported on the distal end of the arch, it usually means they need forefoot posting and they're developing that equad type foot, but they may still be too small to fit into the QuadraStep adult system. So just ask us, we will take a LittleSTEP and we'll add forefoot posting to it, and it'll be amazing. It'll work really, really well. What's the name of the night splint again? I'll type it in the chat for everybody. It's called the Equinus brace. And it's, I think it's called fixequinus.com is the website. Patrick DeHere is the inventor. He's an amazing, amazing man. I think he's president of the APMA, or somewhere he's in the organization. And he is just a really smart guy and has developed this amazing brace. I use it quite frequently. I use it every week in my practice. It's much better than a night splint. And there are some coding things that you should learn about. And I don't want to advise you on that because it's not my place. But if you reach out to that company, Joey DeHere is he runs Thrive Orthotics Lab, and he dispenses the Equinus brace, and he can give you all the coding that you need to know about that brace and how to get maximum billing for it, reimbursement. Anti-pez shoes are good for toe walkers. I don't know too much about that, Ben, but I'm going to look that up. Thank you for the tip. Maybe I can include that in my lecture then. All right, Magdalene, what's the name of the, oh, I already answered that one. What age do you recommend gait plates? Gait plates early, like as soon as you notice it. It could be 1-year-old. Okay, it could be a 2-year-old. LittleSTEPS and gait plates. I'm going to tell you, I work a lot with the early intervention physical therapists who work in school systems and treat developmental delays and kids with medical conditions all the time. And our LittleSTEPS come in sizes 00 to 9. So there's 11 different sizes, and the gait plates come in 9 different sizes. But those sizes will go down. They're really small. They're only a couple inches long. They're really cute. And they'll fit like a 1-year-old. But sometimes these kids have foot development issues and they're even smaller. So these pediatric therapists will be asking me not just for a 00, they'll want a 000, a quadruple 0. So we'll take the smallest one we have and we'll grind it shorter from them. So those intervention therapists who are really, really well trained on managing children, they're using gait plates very early on, because the best time to influence in-toeing is between the ages of 2 or 3. You know, by the time they're 4 or 5 or 6, it's getting harder. When they're 7 or 8, it's almost getting too late. You know, so the earlier you treat, the better. Can you go back to the F-quad Summerly slide? Sure, let me get that up. F-quad. I think, is this the one you want it? Let's see. I'm not sure if this is the slide you want it, Magdalene, but it's up there. This is the one where we were talking about all the different features. And this is on my website too, Nolaro24.com. I'll type that on here. I have a ton. If you go to our education page, you're going to see a ton of information there. If anybody wants to use our website, even if you don't use our products, use our website as an educational tool. That's the biggest thing we have to offer people is education more than products. So call me, even if you're not using our stuff, I'll show you around the website and I'll show you how to learn more because it's all about helping our kids and our adult patients too. Okay, can you explain the difference with medial sky versus intrinsic post? Yes, they kind of go hand in hand, really, because if you have a heel that is pronated, when you invert the heel, that is going to start to apply a little bit of a pressure on the medial heel. But when you're a fabricator, and if you think in the olden days when we pour plaster, which we still do in our office for quite a few patients, sometimes I use CAD, sometimes I use plaster, but we pour plaster just to visualize. You have your positive mold. A medial sky is when you actually remove plaster from the medial side of the heel as it approximates into the arch. And that creates a little bit of a slope or a pressure that creates a pressure underneath the part of the calcaneus called the sustentaculum tali. And so that the calcaneus has that little shelf, that little bony shelf, and in the medial sky just puts a little pressure under that sustentaculum tali so it can't pronate inside the heel cup. So think of it kind of like a doorstop. It's like a doorstop for the calcaneus. It's the best way I can explain to it with no visuals. Let's see. Daniel is asking for resources. Just if you need any of my stuff, just reach out and I will get you whatever you want. What is your recommendation for shin splints? Oh, shin splints, E-quad. You need forefoot posting. The E-quad is a foot type that has a rigid forefoot varus. The number one cause of shin splints is a rigid forefoot varus. Easy to eliminate just by adding extrinsic forefoot posting. You can't treat the forefoot intrinsically if there's a rear foot varus. In other words, you can't take an orthotic and set the forefoot down on the ground. You have to leave it pitched up in that varus angle and fill that. Getting good here. You need to fill in the medial side. Let me see if I have that. Let's do this. Let's go. Here's my website. And you can see underneath the QuadraStep system, you can go to our orthotics. And under our orthotics, you can see all the different quads. Let's go to and click on more information on the E-quad because I'm trying to explain something without a visual. So this will help me out. And you can see the E-quad has a wedge underneath the forefoot, a forefoot platform that extends under the ball of the forefoot. And it has a cutout for the fifth metatarsal head. Because when you're an E-quad on our website, you can go to any one of our quad pages and you can go ahead and play the video, the videos that I was just showing you, and you'll see the E-quad has it's called a medial heel whip. When their heel comes up off the ground, the heels pivot, and that creates pressure under the fifth med head and strain on a constant tug on the medial posterior tib and the anterior tib as well. So you've got to wedge up that forefoot, and if you do, you're going to find that you're going to have really successful results in controlling shin splints, but also, more importantly, in our kids, Eichgrad-Schlatter's and Sever's disease. That's why those conditions happen. Let me see what else I'm missing here. Hope I answered that question. We see neither your cell or number in the chat column. Yeah, so the webinar chat, I see it in there. But anyways, I'll read it off. My email is like my name, Roberta N, and is in like Nolaro, Roberta N at Nolaro24.com. That's Nolaro Nolaro24.com, and can give you my email too. You can always just email to Anne, and she'll get you in touch with me. I always learn something from you guys when I teach a class, so I appreciate that. You never know when you're going to learn something, even if it is Monday night, right, at 8 or 9 o'clock in the evening. And I thank you guys for really sticking with it and staying up late with me and learning. And if there's anything else I can answer for you, I'll hang on for a few minutes. And otherwise, I appreciate everyone's attendance and look forward to hearing from you again. Hopefully, I'll be able to get Anne to arrange a presentation for me to cover more on pediatrics and the release of my NOBOB 10 program, which I'm really excited about. How soon should flatfoot be treated in a kid? Wait 2 to 3 for arch development? Not necessarily. Mag, I don't wait. If I see a kid that's looking egregiously flat-footed, even for a 2-year-old, so remember, Val Massey's rule of 7 says take the number 7 and subtract the age. So if it's a 2-year-old, 7 minus 5 is 2. So if the heel's everted 4 or 5 degrees, I'm not that worried. But if it's everted 9 or 10 degrees and it looks like their ankle is really compromised, that's not good to do, because those are the formative years, those pediatric moments where we're trying to teach normal gait and normal muscle functioning and balancing of the agonist and antagonistic muscle groups. So don't be afraid to treat a 2-year-old. And that's where the NOBOB 10 will help you, because it's going to say, hey, let's look more. I mean, let's face it, you don't get a 2-year-old that's going to come into your office going, hey, can you help me out with this case of plantar fasciitis that I have? They're going to be coming in with their parents and not even knowing why they're there. So the questions are going to be, is there an abnormality in the way they're walking? Is there an avoidance of activity? Does the child want to be carried a lot? Are they crying at nighttime when they're in bed from growing pains? Do they walk on their tippy toes? Is their foot look really, really flat? So there are going to be cues and simple questions, Q&A things. I also wrote a SOAP note evaluation, pediatric evaluation, and I'll share that too once we put this all together. So that'll be ready within the next month or so. And I'm hoping to use this to help people like you not be afraid to treat a 2-year-old, because there should be no fear in it. I think you can treat confidently and know that you're really going to be trying to help that patient, that pediatric patient. Thanks for all the nice compliments, everyone. Appreciate it. I hope I did a good job for you. And I would love to teach you more. I love teaching. So reach out to me and I'll get you connected with go back to the Nolaro24 website and click on the education page, and you're going to see like a bajillion webinars, all that you can learn from. A lot of them have fees associated with them, but if you're one of our customers, we do waive those fees for your attendance. We do use that as an education platform, particularly for some of our PTs and ABC professionals. So those do offer CMEs for C.Peds, orthotists, and PTs. All right, I think we've wrapped it up, and I bid you all a good night, and thank you for staying on so long. Appreciate it. Bye-bye.